Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Italy, Professor Silvio Cerubo. Dr. Cerubo is an associate professor of neurosurgery at the Center for Medical Sciences, University of Trento, Italy, and also the chief neurosurgeon at the Department of Neurosurgery at the Schiera University Hospital, APSC Sanitary Trento, Italy. His clinical interests are focused upon neuro-oncology, neurovascular and skull-based surgery, brain mapping, neurophysiology, and neuroanatomy. He did his endoscopic skull-based training from the University of Naples, Italy, and neuro-oncology training from the University of Montpellier under Professor Hugues Jeffau. And he is a member of the Italian Neurosurgical Society and ACNS as well as the European Low-Grade Glioma Network. He is a noted author with several publications in various leading internationally reputed journals and book chapters. And we are extremely honored to have him today. And today he'll be talking about tractography and anatomical importance in brain tumor surgery. The speaker for the second session of today is our honored guest from India, Professor Komal Prasad. Professor Komal Prasad is a senior consultant clinical lead neurosurgery at the Narayana Health, Bangalore, India. He is a practicing neurosurgeon over 19 years and is also actively involved in postgraduate training in neurosurgery. He started neurosurgery services at the Health City Cayman Islands, an ambitious project of Narayana Health in the Caribbean, and his interests include artificial intelligence, robotics and future of medicine, neurovascular surgery, neuro-oncology, minimally invasive surgery, craniovertebral and robotic assisted spinal surgery. He has a special interest in Advaita Vedanta and consciousness studies in neurosciences. He is an invited faculty to several workshops and conferences around the world and also has published extensively in several peer-reviewed journals. We are extremely honored to have him today with us, and today he will be speaking about artificial intelligence in neurosurgery. The chair for the first session of today is our distinguished faculty and honored guest from Japan, Professor Ken Matsushima. Prof. Matsushima is a consultant neurosurgeon at the University of Tokyo, Japan. He was a previous fellow in the Microneurosurgical Anatomy Laboratory under Professor Albert L. Rotten's mentorship in USA, focusing on skull-based surgery, which includes the jugular foramen, venous system, temporal bone, and brainstem. He also studied surgical management, particularly brainstem surgery, under Professor Helmut Bertalanffy in Germany. His clinical interest has been widely published, including 2 front covers of JNS, and also received several national and international awards such as Young Neurosurgeon Award from the WFNS and Raymond D Award from the ISPN. We are extremely grateful to him for accepting our invitation to chair the first session of Professor Silvio Cerubo. On behalf of the Education Committee of the ACNS and the President Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Seng from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Prof. Ken Matsushima.
Thank you so much for your kind introduction, Raja. Good morning, good afternoon, and good evening to everyone around the world. I am Ken Matsushima from Tokyo, Japan. It's my great honor to introduce today's first topic, brain anatomy via tractography and its application in brain tumor surgery. Precise understanding of white matter anatomy has become increasingly important in modern neurosurgery. Techniques such as tractography and fiber dissection provide valuable insights that greatly improve surgical safety, especially in tumor surgery involving the eloquent areas. Today, I am very glad to learn with all you guys from Professor Silvio Cerubo from Italy, who is a leading expert whose work has greatly advanced this field. Professor Cerubo, please start your lecture when you are ready.
Thank you very much, Ken. Before starting, please let me thank you, Raja, and all the board of the ACNS for inviting me to this amazing meeting, but especially in this prestigious academy of the ACNS. We really take into account a lot your community in the world of neurosurgery. Okay, so my goal today is trying to give you exactly an overview of what tractography really changed in the world of neurosurgery. I don't want to be too much technical about tractography, about methods. You know that tractography it's big evolving world with a lot of technical pitfalls that are still a big work in progress. But what really did tractography in our world in the last 10 or 2 decades, we can say, cultural innovation, technological innovation, and conceptual innovation. I will try to overview this big 3 chapter and to show you also some cases that could highlight what is exactly our change of mind with tractography in our departments every day. First of all, tractography gave us the opportunity to study and to analyze the white matter connection within the human brain. It changed our view of the pathology instead. We know very well since many times now that high-grade and low-grade glioma, for all the kinds of glioma, we can say now the resection is still now the treatment more impacting on the overall survival. We proved that. And we know at the same time that resection, aggressive resection of brain tumors, especially of high-grade gliomas or more aggressive tumor, needs to preserve the perfect connectivity of the human brain. This is the only way to obtain the best overall and extended outcome, cognitive outcome in our patients. And in fact, in the last years, we are also changing our real role in the resection of brain tumor. We are moving our concept of complete resection, especially in high-grade glioma, from the contrast enhancing area to the hyperintensity infiltrating portion of the tumor. And different groups, not just our group, proved that this pushing the resection beyond the classical contrast enhancing border can provide significant improvement in the overall survival. And we are doing more and more. We are also now able to define some threshold that can be useful to really assess an improvement in the expected overall survival of our patient. In this wonderful paper by Luca Zigiotto, published recently in Neurosurgery, we demonstrated that resection of 40 cc of residual tumor inferior to the 40 cc of residual hyperintensity in high-grade glioma can produce a significant improvement in overall survival of our patients, preserving the extended neuropsychological or neurocognitive outcome of our patients. So, what was the first change that tractography provided us? A conceptual change. In fact, we are now talking about connectomic neurosurgery. This is probably too much, but it's something that is pushing us to new perspective in neurosurgery. We have more and more tools. I want to show you this new tool, for instance, for surgical and clinical activity that allow you to track the white matter pathways on the base of your anatomical knowledge of the brain and no more through ROIs or atlases. This is very interesting for us neurosurgeons, I think, because it allows you finally to track more and more reliably, not just in a healthy subject, but especially in pathological context. And what the community did over the last years was to make tractography more and more reliable. How we did it? We did it through the renewing of the microdissection technique and creating more and more tools that allow to assess the reliability of our tractography methods, and especially to redesign completely the anatomy of the associative pathways of the human brain. You see here Bradifo, that is one of these tools. This is you can freely download from this website models dissected by me and my group, and integrate this with your tractography for different reasons, for improve your didactic knowledge of the human brain, but also to check the availability of your tractography methods. This wonderful paper by Laura Bavassori will be soon in Nature Communication. And thanks to Bradifo, thanks to the continuous advancement of microdissection integration with tractography, we are now redefining completely the anatomy of the, for instance, superior longitudinal system or inferior longitudinal system, trying to providing to the community more and more reliable knowledge of the human brain anatomy. But this is not all we need. We need also tools to making together the anatomical information with the functional information. You know that resting state appeared in our world recently. Resting state is a functional MRI technique that is very convenient and is very useful in the clinical ambient, I think. And resting state is now available in different automatic pipeline. I just show you this pipeline from our group. Recently, we published a revision of this pipeline, new version of this pipeline in Neurosurgery, that allow you to extract at least the most critical and most well-known functional network in the human brain, in order to give you the chance to merge the functional information with the tractography, and so the white matter anatomy information. Resting state is giving us also more and more information regarding the ability of our brain of our patients to reorganize even after surgical treatments or radiotherapy, for instance, for both low and high grade glioma, and to understand also some predicting factors before the surgery, to understand what will be exactly the cognitive outcome of our patients for some cognitive domain, like attention, memory, or language, for instance. So this conceptual change, together with the widespread use of direct electrical stimulation with the patients or intraoperative neurophysiological monitoring, gave us more and more information also regarding the role of this white matter. We did a first attempt with you before many years ago, in 2015 in human brain mapping, and more recently in Neuroimage, to assess which of these pathways are more important for the different functions that we can monitor during the surgery. And now we move a step forward in this field, trying to join the information, the previous functional information coming from the direct electrical stimulation in awake patients with tractography. This is our last paper about atlasing the brain using direct electrical stimulation points, an unprecedented number of direct electrical stimulation functional apps, from more than 600 patients submitted to resection of brain tumors, that were used for a causal mapping using 1,000 healthy subject resting state fMRI, starting from each of these points as seed points. And what we obtained was an unprecedented atlas of the human brain, merging the causal information, the unique causal information of the DES mapping, with the powerful of the resting state analysis in a large cohort of 1,000 healthy subjects, and allowed us to create a threshold maps of all the main functional domains in the human brain. We tested the results of the atlas using different datasets coming from TMS, for instance, coming from stroke, coming from stereo AG in epilepsy surgery for different functional domains, and also using new population of patients submitted to resection of brain tumors to predict the possible transient and permanent postoperative deficit. And what was very interesting was that this atlasing of this new way, this multimodal way to atlas the brain functions using DAS, ResiState, and Tractography together provided a solid tool in which just the 10% of clinical population are outside of these maps. So it's a sort of message for us that not all our patients are totally out of our chance to plan exactly not just the surgery but also the outcome. And this tool can be useful to define exactly which is the subset of our patient that really needs more and more efforts to define their functional predictive possible outcome in different domain. Then we have more different conceptual innovation. What I mean for conceptual innovation in surgical technique is not, the long-lasting discussion between superior or subarachnoid. I don't have clear idea about that. Sorry.
It got disconnected.
Raja?
Yes, please.
Oh, I'm sorry. The PowerPoint. Can you see the screen?
Yes, yes.
Okay. Okay. I start again. So what I mean is not the classical discussion between a superior or a subarachnoid approach. I try to arrange as best as I can my technical ability to the case, and I don't want to discuss if it's better to operate the patient awake or asleep, even if I think that, of course, all the time that you have the chance to have an awake patient with direct electrical stimulation, this is very usable. This is very useful for you to check exactly the real limits of your section. But a more functional oriented technical resection in neurosurgery. We know since many years, for instance, the anatomy, the dual stream anatomy of the language processing. And in this view of this functional view coming from the neuroscience world, we have a dorsal and a ventral stream. This is a seminal paper by Hickek Popel published in Nature Neuroscience in 2007, in which reviewing and meta-analyzing a lot of famous and very solid neuroscientific papers, these two authors tried to summarize exactly the cortical organization of the language model. And we know from our atlases, for instance, that this organization is reliable, for sure. The schematic organization is reliable, but we have a big overlapping between these different functional subdomains within the brain. But we never had, before the last 10 or 15 years, a proof of what was exactly the connectivity of all these subnetworks that really subserve the language processing in all the different modalities of the language output. We know now, for instance, that different and crucial connectivity structures in the human white matter play a crucial role in each of these subdomains. We will overview quickly this, like the dorsal stream, arcuate fascicle, the superior longitudinal system with the so-called SLF3, with the transverse system that is crucial integrating the supplementary motor area with the ventral premotor cortex and the whole ventral semantic system that include, in fact, the IFOF, but also the uncinate fascicle or the inferior longitudinal fascicle. So this is just to tell you that we have now a clearer idea of what is, at least schematically, of course, which are the pillars of the functional organization of the brain in terms of different functions, of submodality of functions. And this is very useful now because we can plan our surgery, we can plan our mapping, we can plan our surgical strategy with this information, looking at this information in our minds. Let me start by the dorsal stream. We know very well the anatomy of the dorsal stream. And as I showed you before, we have more and more information now for atlasing again the dorsal stream and particularly the superior longitudinal system that is composed, by 4 portions, starting from the more dorsal frontoparietal white matter to the more ventral frontoparietal white matter, with the adding of the direct frontotemporal connections observed by arcuate fascicle. The dorsal stream is crucial in all what we can define as the organization, the motor organization of the language. If you look, for instance, at the distribution of the functional response of the verbal apraxia in our atlases, you will note that these main hubs at cortical and also subcortical level are distributed between in the superficial white matter between the ventral premotor cortex and pars opercularis and the inferior parietal lobule, so supramarginal gyrus and angular gyrus. The main layer of superior longitudinal system connecting these two cortical regions is the so-called superior longitudinal fascicle third portion, or indirect anterior superior longitudinal fascicle. You know that we have a big heterogeneity of nomenclature in the human white matter, and in fact the community now is doing a big effort in trying to clarify and to make this more and more homogeneous. We have clear neurophysiological proof since many years now, thanks to the seminal work. Let me say seminal work of Riki Matsumoto, published in Brain, that for the first time in the story of neurophysiology and neurosurgery also assessed the direct cortico-cortical evoked potential pathway joining the ventral premotor cortex with the inferior parietal area. And we know now, thanks to the multimodal studies coming from direct electrical stimulation, resting state seeding analysis, and tractography, that this bundle subserver real network, we call this the speech articulatory network. This network is crucial in managing the sensory input and the motor planning of the language, so the articulation of the language. By observing this network in different modality and multimodality, we obtained all the time the same results. We have a big functional connectivity between the most ventral part of the precentral and postcentral gyrus, including the inferior parietal lobule, ventral premotor cortex, and pars opercularis. And even when we try to include in the analysis the DES negative points, because you know that the community is is so much interested to the DES negative points, the results never changed. And in fact, the kind of connectivity maps that you can see in the last version of these studies is totally the same in respect to the just DES positive studies. What is very new in this atlas is that for the first time we established a threshold for using the atlas maps and the DES atlas more in general maps in defining sensitivity and specificity for predicting possible functional points in this region. Moving through the dorsal sub-functions of language organization, we have phonology. If you look at the distribution in our atlas of the cortical and subcortical functional points in the brain of our patients, you will notice that these kind of functions are more distributed in the deep white matter of the encircling the insula. Okay, so we know very well that we have a big structure here that is the arcuate fascicle, or fourth component of the superior longitudinal system, as you prefer. The arcuate fascicle anatomy was described for the first time 1 century ago. And it's unbelievable, because if you look at the literature regarding AF, you will notice that AF is included in a lot of functional stream in the human brain, functional functions in the human brain, including, of course, speech production with the verbal fluency and phonology, but also social cognition, verbal memory, and so on. This is not surprising, because arcuate fascicle has a big distribution, connecting directly. This is the main definition of the arcuate fascicle, the ventral region of the frontal lobe, and particularly pars supercularis and the posterior third of the middle frontal gyrus, with entire temporal lobe, T1, T2, and T3. And in fact, Fernandez Miranda, not recently, but 10 years ago, provided the first subcomponents description of the AF. Of course, the AF is not exclusively the mainstream of the phonology loop, but is crucial for us neurosurgeons, because in all the resection that include the prefrontal region, the central region, the post-central region below, and beneath the ventricular system, but also the big anterior temporal section, we can find functional positive points regarding AF in language. If we move on the other side, if we move on the ventral functions, if we move on semantics, that is crucial, is a crucial function, because semantics is in fact the real link of the evolution of the human primates. Semantics is the basic of consciousness and the basic of our individual feelings, of awareness of everything. And semantics, if you look at the distribution of semantics in our atlas, you will notice that these kind of functional points are completely segregated in respect to the dorsal pathways, and are distributed in the deep white matter of the temporal lobe, on the entire temporal lobe, occipital lobe, and then through the anterior third of the ventral of the external capsule within the deep white matter of the frontal lobe. This is the course of the IFOF, the inferior fronto-occipital fascicle. IFOF is the longest associative pathways in the human brain. IFOF has my friends, a strange story. It was described, and even the first description of the IFOF was largely discussed, and different ancient anatomists at the end of 19th century reported IFOF. Since Curran or de Gerin reports, we know that we have this big structure connecting directly the occipital lobe, the precuneus, the basal temporal cortices, through the anterior third of the external capsule that we normally call stem of the IFOF, by a big fan of fibers through the entire frontal lobe, including the inferior frontal gyrus, the middle frontal gyrus, the superior frontal gyrus, and the frontal pole. IFOF is a crucial factor in neurosurgery because IFOF was demonstrated to be the mainstream of semantics. Semantics is crucial for comprehension of language and comprehension of everything, to be totally honest, and to summarize the role of semantics in our life. And especially because this long course make IFOF a structure that we face in all kind of resection, since the basal temporal area through the entire temporal lobe, but especially within the insula. Within the insula, you can see here the resection of the complete resection of a pure insular low-grade glioma. The resection in the insula by superior approach, the IFOF constitute a crucial landmark, because if you can find constant semantic paraphasia or anomia due to the stimulation of the anterior third of the external capsule, and particularly to the stem of the IFOF, you exactly define the depth of your surgical cavity, because you cannot go through this, and you protect your resection to face the region of the anterior perforating substance, and you have the perfect corridor to remove the entire insula without entering the other fibers of the internal capsule, the basal ganglia, the internal capsule, and once again the perforating area. IFOF is a crucial structure because IFOF is also a landmark for other structures. For instance, the optic radiation. With Alessandro De Benedictis in 2014 reported this anatomical paper, really simple anatomical paper, using some lights within the ventricle and analyzing the course of optic radiation, demonstrating that in all the specimen, the superior optic radiation run exactly below the full course of the IFOF. That means that if you are able to stimulate the IFOF in this area, you can check together the visual field and the semantics. And this is crucial because you can, if you have this anatomical knowledge about IFOF, you can perfectly sculpture your resection, avoiding a myopia and resecting entirely your tumor, providing to your patient the best outcome in terms of functional outcome. So here, just some case to show you what tractography changes. You see here easy case, really easy case. This is a small high-grade glioma in the medial-posterior temporal lobe. You can just resect the contrast-enhancing area with no problem, with no troubles, with no needs of a weak surgery on special tools like tractography or resting state, or tractography with resting state, or task-based fMRI. But you can choose also to do something more and to push your section beyond this pure contrast enhancing area, because we know very well by PET study that most of the tumors is around this, and your relapse in this patient will be around your cavity. And how you can do that? You can plan your surgery trying to assess exactly which of these bundle, dorsal and ventral, really run around your tumor. Tractography is very useful. You can see here which kind of wonderful reconstruction you can do of the AF, that embrace this tumor with the terminal portion of the bundle within the T2, T3, middle and posterior T2 and T3. And you know that when you have resected this tumor, on the roof of your cavity, you will have the fibers of the AF. And on the floor of this cavity in the depth, you will have the fiber of the ILF, so ventral stream, like IFOF, and so semantics. And in fact, what is the results of the resection is very easy, you know. After resection of the pure portion, enhancing portion of the tumor, we push the resection, checking with the simple object naming and finding you see here 43 that is phonologic, exactly the fibers of the AF terminating in the T2 and T3, and semantics on the floor and on depth of the cavity due to the fibers of the IFOF and ILF running to the temporal lobe. This is another case, more complex case. All of you face this case every time, but you can choose to select which kind of structure you don't want to destroy. Not just for language, so no more just AF, no more just IFOF that you see here reconstructed, but is very, very destroyed by tractography. But at least you know, you can understand what is the position of the IFOF in respect to the landmark of your resection. So in the depth of the anterior perforated substance, you will find here the fibers of the IFOF that you are able to reconstruct. But especially a new structure, we will see the functional role of this, the frontal aslan tract. The Japanese school demonstrated since many years the big role of frontal aslan tract in organizing the speech output and the big troubles that your patients can have in destroying frontal aslan tract, for instance, in verbal fluency. So, of course, and once again, you can do this tumor in different way, but you can do it better if you know exactly all the structure, the eloquent structure that we know at this time, of course, that harbor around your tumor. And look at this video. After the big resection of the main part of the tumor, we are pushing now the resection to find just these three landmarks. So posteriorly, the fibers of the dorsal stream, AF and SLF, evoking verbal apraxia. In the depth of the insular corridor, the fibers of the IFOF running up to the dorsal frontal lobe, and posteriorly and dorsal, the fiber of the FACT. And you see also the results, that is a big resection of the entire hyperintensity T1 and hyperintensity T2 with no troubles, no functional troubles for the patient in the longer at the long-term follow-up. Another case here of a pure high-grade glioma of the insula. Of course, you can do this. You can do this in different way, but look at this planning. This is very, I think, useful for the surgeon, for the neurosurgeon, to know exactly which is in a patient that is able to perform object naming, that he has a good preoperative cognitive evaluation to know exactly which are the fibers of the IFOF and which depth will be the resection in respect to the fiber of the internal capsule that you see here are very close. So once again, the resection is easier because the debulking of the pure high-grade and necrotic part of the tumor, we can stimulate and to push the resection at the real limit here, at the level of the fibers of the IFOF. Okay, another complete different story in terms of in terms of functional assessment, and fibers connecting are the motor system. So I don't want to bore you with the story of the pyramidal tract and so on, because pyramidal tract is the first tractor that we were able to monitor thanks to intraoperative physiological monitoring, thanks to the monopolar subcortical stimulation and cortical and transcortical MEP. But movement is not just the motor response. Movement is more and more complex, and this complex bihemispherical network that is observed by a crucial planning activity. You see here the negative motor network response in our atlases, and you will notice that these are homogeneous distributed between the deep white matter of the left and right frontal lobe. And I want to show you something regarding something new that we recently discovered about the motor network. You see here, I really hope you can hear, stimulation in a frontomesial resection of the fibers running from the supplementary motor area, the most crucial portion of the supplementary motor area, and are running down to the basal ganglia. And you will see that we have a pure motor arrest here with the patient that is not more able to communicate, but also to move. So this is a pure and complete motor arrest. This is due, in fact, to the deactivation of the motor output from the residual portion of the SMA, in this case, that is crucial and is not plastic, as we told for many years, and run down to the basal ganglia. And then we have a segregation also of the motor planning. Like for the speech planning, you see here the distribution, for instance, of the pure speech arrest. So not complete movement arrest, but exclusive speech arrest. And you see here that the dysfunctional response are more distributed in the lateral white matter connecting the supplementary motor area with the ventral premotor cortex. And in fact, if we go again in a frontomesial case, in the resection of a frontomesial case, and we stimulate no more, in this case, the fibers running down the most crucial portion of the SMA to the basal ganglia, but the most lateral white matter connecting this SMA with the ventral premotor cortex transversally, like here, this is the fact, you will notice that the response of our patients will be totally different. So the patient continues to move the upper limb, but she starts to stutter. So we performed a motor block of the speech planning and not an entire whole movement arrest. This is due to the deactivation of this direct connection between the SMA and the ventral premotor cortex that was described for the first time by Marco Catani in 2012, and we call FACT, and we know that FACT is crucial. We know this by different voxel-based injury impact studies, that is crucial for semantic and phonemic fluencies outcome of our patients. We know also that we have a lot of other projecting and structures that we can reconstruct by tractography. You see here, for instance, the fibers of this is a constrained spherical deconvolution, very advanced tractography technique, so sensitive, but not so specific, to be totally honest. And we have a clear reconstruction in this pure post-central low-grade glioma of what is exactly the location of the tract that is divided in two parts. And we try by direct electrical stimulation and awake patient to define exactly all the different portion of these descending fibers from the postcentral gyrus, ensuring to the patient a complete resection. So once again, tractography is not everything, but is very important to orient the mapping of the surgeon and to reduce also the timing of the to the stimulation and to improve the outcome. Just before to close, and just to remind you that tractography and functional studies more in general were crucial to let us understand that also the right hemisphere is crucial for different functional domains, and especially for spatial perception, for instance, that is strongly right lateralized in most of people, and that this spatial perception network is not a localized function, but is a network. Is a network that includes a frontoparietal direct connection subserved by the second portion of the SLS, the so-called SLF2, since some years ago, that connect the intraparietal region with the posterior third, in particular the posterior third of the middle frontal gyrus, where we have also the frontal eyes field that are part of this network. And in fact, just to show you quickly what we discovered in this paper by Luca Zigiotto that I mentioned at the start of my talk, in exploring what is the role of our ability to predict the outcome in terms of attention and working memory. And this is very nice because, you know, we don't have any kind of system to assess exactly the risk and to map intraoperatively, but we can monitor this function. And we discovered by this box-based symptom mapping and tractography connectivity and resting state study that this attention network is a frontoparietal network, once again connected by the fibers of the SLS with a big hub in the cortex, in the mesial cortex of the inferior frontal lobe, and that preserving these fibers and preserving this cortical area, monitoring, of course, our patients in terms of attention during surgery, can really change the outcome in this kind of surgery. Tractography will be more and more in future because the progresses of tractography are strongly linked to the progress of techniques, and you know that everything is linked to the progress of technology will be more and more better in future. This is just to show you our last paper by Chiara Riccardi and Paolo Avesani. To be totally honest, we are co-authors. We supported them in this deep learning and transferred learning pipeline, trying to focus on the automatic tracking of the white matter crucial bundles in pathological condition, and particularly in brain tumors, obtaining good results, encouraging results that have to be improved more and more. How? With improving our knowledge, the knowledge of neurosurgical community in white matter anatomy, with microdissection, with tractography, integrating macrodissection and tractography, integrating the information coming by resting state and other functional tools, by direct electrical stimulation and intraoperative monitoring results, voxel-based studies, in a new concept of neurosurgery that has the functional system of our patients in the focus, and no more the tumor or the other structure that we want to reach within the brain. Let me thank, please, all my collaborators in Trento, neuropsychologists, PhD, postdoc. All the people are working with us with more than 10 years now, and you for this really kind invitation. Thank you very much.
Thank you so much, Professor Sarubo, for this excellent and a very inspiring lecture. I'd like to open the floor for the question and comments. Any comments in the chat box? Not yet.
So far, none. You can say your comments.
Okay. Yeah, while wait, let me ask one question. Your tractography images were really beautiful. It's amazing. They looks perfect not only with healthy volunteer, but also with brain tumor patients. Could you please share some of the key techniques or tips to make such high quality reconstruction, especially when you have the mass effect or a peritumor edema, which can distribute the tractography?
Thank you, Ken, because this question allowed me to complete the presentation. My goal today was not to bore you, with all the kind of algorithm that you can use, but I want to surprise you. I want to surprise because all the images that you see in this slide are images, I mean the pathological images, not healthy subjects, but glioma patients' images are images that we reconstructed by 1.5 Tesla MRI. Okay, so tractography is a big word. We found that recently they found that and they included me, and I really suggest to the Asiatic community to move in this world, in the world of the International Society for Tractography. So the best experts in the world are trying to define what is the best algorithm in the clinical condition. What is my experience, for instance, is very basic. 1.5 Tesla, 60 direction, that I think is the minimum to have good images, a good post-processing pipeline. We can share our protocol with all of you if you want. They arranged the FBK Foundation and NILAB by Paolo Avesani arranged for us this pipeline since 15 years. Of course, updating these year by year with some novelty, and then the last thing, the algorithm. Okay, there is a big discussion, about deterministic and probabilistic, and about constraining spherical deconvolution and other. We don't have any kind of proof in the neurosurgical literature since now about the fact that deterministic or probabilistic or CSD is better, and even that tractography alone is better in the operative room. So we soon will be out with a paper trying to assess if deterministic and probabilistic, which is the difference in outcome between probabilistic and deterministic. In my personal experience, I strongly suggest you to have a good deterministic algorithm for all is associative. Okay, so Arquette fascicle, IFOF, Uncinate, and so on, because we neurosurgeons are not interested to exactly understand all determination, but just to assess where is the bundle in respect to my tumor. Okay, and to use constrained spherical deconvolution and probabilistic for pyramidal tract and FAT, because these are very arching pathways and are very hard to be reconstructed. With the deterministic one. So this is my personal suggestion after 15 years of use of tractography. Lastly, and then I close. I strongly suggest to all the neurosurgeons around the world to reconstruct the images by themselves in the department, losing time, because this is very useful to understand the white matter anatomy and to improve your knowledge, and also to obtain more and more realistic and good reconstruction.
Thank you so much. It was really surprising for me. Thank you.
Thank you. There is one raised hand from Dr. Uday Bharti. Yes, please go ahead.
Good evening, sir. I was exposed to connectomics when I was being trained at King's College London and during my training at Omniscient. I think the frontal ascending tract, which you mentioned, is very important. Just a comment, we can use MIPS approach, that is minimal invasive parafascicular approach during our connectomic dissections and improve the outcome of the patient. And that will help in the cognitive outcome of the patient.
Okay, so my personal feelings is that the knowledge of the human brain connection is something very new and very useful,
Yes.
not just in glioma surgery, but in a lot of surgery. I wrote some papers and I use these, for instance, to reach deep-sided cavernoma and so on. But we have to distinguish between what is the goal of your surgery. So, in glioma surgery, to be totally honest, at the moment, and I really hope, and we all really hope, the entire community hope, I think that we will have some chemotherapeutic new options soon. But at this moment, this is a big demolitive surgery. So I don't trust so much in this kind of surgery in minimum invasive approach. Because to be honest, what I think is that the goal of the surgery is to expose more and more the white matter and the real critical boundaries of the tumor. On the other hand, I think that, for instance, to reach the ventricular structures or to reach deep-sided lesion with no needs of demolitive surgery, this kind of approach is very useful. And once again, tractography is more and more useful because, this is an healthy brain, and to recognize these pathways is more and more easy.
Just one comment, sir. If we use the parafascicular approach for tumors, then also we are not sacrificing the white matters, and we can incorporate the connectomics, and then can we reduce the craniotomy size and work it out, because parafascicular is also saving the white matter and all the tracts if we are going transsulcal.
Yeah, the problem, that I think that is the word connectomics is a bit abused. I also use it, but is a bit abused. It's very hard to say what is connectomics, what is crucial and what is not. And we are really at the beginning of the story, guys. We really don't know exactly which part of the entire connectome is really crucial for our patients, or for the different patients in a different pathological model. So I think that the entire reconstruction and this merging between, with no studies regarding the reliability of the results, that is another question that I'm trying to raise since many years now, because we don't have any kind of proof of what are the results of the different tractography approach is very dangerous in neurosurgery.
Well, thank you. Thank you very much for this very wonderful talk. It was indeed a two-day course into the tractographic arena of neurosurgery. So we'll take the final remarks from Dr. Ken Matsushima before we move on to the second session.
Yeah, thank you so much. I don't want to take time for myself. Thank you. We will conclude the first session, and please, I would like to hand the chair back to Dr. Raja for the second session. Thank you.
Thank you. Thank you very much. I would like to thank both chair and speaker, Professor Silvio Serbo and Dr. Ken Matsushima, for this very interesting and elaborate session on tractography in brain tumor surgery. I would like to inform our viewers that this has been broadcasted on WeChat, YouTube and Zoom. And thanks to Professor Shubin, now we have around 570 people who have logged in through all the different channels. So we'll move on to the second session. So I'll hand this podium over to our second speaker, Dr. Komal Prasad, who will be talking about AI in neurosurgery.
Good afternoon, good morning, good evening for people who have logged in from various different parts of the world. And first of all, thanks to Professor Yoko Kato, her team, and Professor Raja Kuti for inviting me for this very interesting intercontinental webinar. So my topic for today is artificial intelligence in neurosurgery. So in contrast to the previous talk, which was focused more on one particular aspect of neurosurgery, that's tractography, I am going to take a overview of what artificial intelligence is and how it is impacting us as neurosurgeons. Okay, there are many AI generated images in this presentation. It is an overview of how AI, which is bombarding us from in social media, in regular media, in our academia, how it is impacting our practice of neurosurgery. So that's the theme for today. So I come from Bengaluru, which is in the southern part of India, a hospital chain called Narayana Health, and this is the place where I work. So we have a multi-specialty unit and a large academic neurosurgical unit where we practice all aspects of neurosurgery. And the new additions in our team is the Mazer-X robot, which kindled an interest to look more into robotics as well as AI in our field, which is in a very curious way, like we learn as much as we learn in the academia through the media, as well as our own patients who bring data which have been generated using AI, as well as the information available in the net. So this is what prompted me to get into this field some time ago. And it's not like we have done any cutting edge research into this field. We have some report about very preliminary steps into how AI can be incorporated into surgical decision making, which I will be touching. But the crucial question is the one which bombards us often times, that like who would we trust more to predict our patient's outcome? So these are kind of questions which we are going to get now, which were looking like a fantasy and may be coming in some future time. But now we are in a time where we have to grapple with these questions right now. Do we trust our years of surgical experience, or do we rely on a machine which is trained on 100,000 cases, which is definitely possible in a short span of time? For example, to predict a patient's outcome who is getting operated for a anti-communicating artery aneurysm. So definitely the machines are capable of much more than our individual surgical career can teach us. So in this session, I'll be going to touch upon how the practice of medicine as such and how the practice of neurosurgery has evolved over time. So we'll zoom back to see like what are the technological evolutions and how we have incorporated that in our practice over last 100 years or so. Then we'll touch about what is artificial intelligence, the basics of AI, and what's its utility in neurosciences as of today, what are its limitations, and what's the future. And then we come to the time to grapple with the real question, like if artificial intelligence can do most of the jobs, almost everything, including thinking, memory, empathy, of what humans can do, what remains as natural intelligence and what it means eventually to remain as human, and what differentiates us from machines. So those are the philosophical questions which we'll be touching in the end. So this is a kind of general talk. It's a kind of thought-provoking, and I invite you to note down any questions or doubts, whatever you get, and we'll come back to that in the end. So this is our hero, Harvey Cushing. So it is very interesting to know that he was also a prolific writer, and he got Pulitzer Prize for his biography of Sir William Osler, the father of modern medicine. And in that, he quotes Sir William Osler, a very important thought for us, where he says it's much more important to know what sort of a patient has a disease than what sort of a disease a patient has. So rather than concentrating on the disease, so it's much more important in practice of medicine to concentrate on what sort of a patient is he who is having the disease. So this is a underpinning principle of medical practice through the ages, and this is something which machines will take a long time to grapple with. So if you see the evolution of medicine in the last 100 years, so this was an article in Medical Economics, and if the upper part of the image shows the toolkit of the medical doctor 100 years ago and what is it at present. So can you imagine, can you guess what would be the only tool which we are using, which was being used by the doctors those days? You can see the image, you can see the only thing which is common there is our handy knee hammer, the tendon hammer, which is used to elicit the reflexes. Other than that, we are having a lot of this electronics as well as new gadgets, which will be helping us in diagnosing and coming to the planning the next stage. So the evolution of practice of medicine for us as doctor, basically we are all doctors, though we have specialized, subspecialized into many avenues of neurosurgery. Well, we have to remember our past, how we have evolved over years, which was an art those days, has now become a proper science. And people who, like we were wanting to be called as doctors, but nowadays, like we have become specialists in particular aspect of one subspecialty. And where there were earlier house visits and clinics, now we have huge hospitals, which we are used to and we take it for granted. And the patient who was a person, a fellow human being who comes to get care, has now gradually evolved into a consumer, like how it happens in other businesses. So it has various different implications, socio-economic, medical, legal, everything. So this, but we need to be aware of how we have changed over years. So to see how the practice of medicine, doctor-patient relationship has evolved over years. Earlier traditional model was the paternalistic approach, and our generation, in the last 40 years or so, we have seen the evolution happening very rapidly. We have seen this paternalistic approach where physicians were the sole decision makers and patients were passive recipients of care. There was high level of trust, and doctor would say, I say, you follow that and you will get cured. And there was a high level of trust. The focus was on achieving the best clinical outcomes. So there was limited emphasis on patients' personal values or autonomy. Then came patient-centric care, where the decision-making became shared, like patient was given some autonomy and his right to choose a treatment for ensuring their values, preferences, and circumstances, which was central to medical decisions. Communication improved, there was eye-to-eye contact, the reports were discussed, treatment options were discussed. So we have seen this, which happened in the 1980s, 1990s. Then came empowered patient with the advent of internet, where the internet brought in digital health, patients with access to medical knowledge through online resources, empowering them to research their symptoms, treatments, potential diagnosis independently, and they used to come with the reports, which we have seen. So I just want to bring your attention to how we have evolved in the last few decades. This is a cultural transformation which have happened in front of our eyes. So this leads to an equal level partnership between the doctor and patients. So this new set of patients can be called as e-patients, who are empowered, engaged, equipped, enabled with equal level of knowledge availability with their caregivers. That's digital health. Patient empowerment is the biggest milestone in the history of medicine. That's a cultural transformation where patients come to us with the reports, with the treatment options available, and suggesting which one, and just to get a validation about their selection of treatment approach. From there, we have jumped into a new era, artificial intelligence driven healthcare, which is just coming to our day-to-day practice in an insidious way. We are not noticing it, and if we don't give a thought about it, we'll miss how radical this change is happening. Now both doctors as well as their patients are looking into not just the reports, but the interpretation of the reports using machines which have data from hundreds of thousands of cases. In the academia, we have seen, for example, in spinal surgery literature, we have seen how a logarithmic scale, how the literature is being pumped in every year the spike which we are seeing in the 2020s, the application of artificial intelligence in spinal surgery as well as in neurosurgery. So we have to keep in mind, like any new technology goes through a hype cycle. It's the Gartner's hype cycle, and there will be whenever there's a new technology, there will be an innovation trigger, and that gets followed by a peak of inflated expectations. Whether you take it MRI, a CT machine, internet, or robotics, artificial intelligence. Every new technology will have to go through these 5 stages. There will be innovation trigger which fuels a peak of inflated expectations. Then over time, when people realize it's not worth the hype, so it has its limitations, then there will be a trough of disillusionment. Then a kind of balance appears, a slope of enlightenment, and then there will be a plateau of productivity. What we really have to note is that the plateau is actually at a higher level of a different dimension than the point where we started from. So I'm taking some examples of how AI has made a change and which impacts us in our day-to-day practice, which are actually real and which are available in the market today. I'm not taking those isolated cases where they are still in the research publications. So this is about Google LM, which is able to solve USMLE, clear USMLE examination, the toughest standard for medical examinations, as good as or even better than an average medical student. So in this one is taken from Medical Futurist, a blog from Hungary, which was nicely encapsulates where all AI has touched upon in lives of medical professionals as for the patients. Documentation, creating discharge summaries, generating clinical notes, insurance pre-authorization, summarizing research papers, which is possible in our handheld devices, interpretation of radiology, suggesting treatment options, designing treatment plans, diagnostic assistance, and for the patients, their symptom assessment, apps are available, mental health chatbots, interpreting physician notes, disease descriptions, analyzing laboratory tests. So these are some aspects which have been practically being utilized with the advent of AI. And Microsoft has its clinical notes generating software Nuance, which is available in the market. And there are many other competitors for this, which can easily translate and avoids that work of the physician typing his notes in EMR. And coming to neurosurgical aspects, this Cure AI, this is an Indian company which has an app for stroke care where the CT is fed directly from the machine as soon as the patient gets a stroke call, and then it detects any large vessel occlusion, aspect ratio, and sends a message immediately to the whole team, and which can prepare for thrombectomy. The Rapid AI has become a benchmark now, and it has been integrated into AHA flow care pathway for managing large vessel occlusion based on aspects ratio, which has widened the therapeutic window for thrombectomies. And for volumetric aneurysm measurement, again, it's again as a part of Rapid AI. And medical robots for medical delivery between the wards. So these are controlling assistive robots. And autonomous patient triage and navigation, which is very useful in ER. And in the cancer detection and diagnosis, analyzing pathology scans and samples, it has given a new dimension where over time, I presume the classification, the traditional classification systems which we go through now as grades 2, 3, 4. Now with the advent of IDH mutation in glioma, for example, we have noticed like it's much more important to know the IDH mutation status than just labeling as high-grade glioma. So a similar hundreds of such insights can be gathered by AI, which would see the overall prognosis, overall survival data of hundreds and thousands of patients. And in a pathologic point of view, to detect the grade as well as to classify and subclassify, and even based on histopathological samples, so to detect IDH mutation status. So these algorithms are being trained for that. Fall detection sensor systems, which is available for home use. So what we can see is like the distinction between academia and what was available to the patient is getting blurred. Those days of the centralized care where the new technology was available only in big multispecialty hospitals is getting democratized so that these are available in patients' handheld devices. So, about performing therapy as chatbots in psychiatry, psychology, psychological counseling, Obot utilizes chat methodology to counsel the patients and see any alarms and to alert the physician. And eCart is predicting patient deterioration in real time. So these are the early warning signs, which are the scores which are generally manually noted by the nursing professionals, which is directly taken from the monitor, and then early warning signs are alerted to alert the treating intensivist to see if there is any pupillary asymmetry, if there is any bradycardia, hypertension. So those are the automatic alarm systems. This is one marketed software. So with this, we'll come to touch some basics on what is AI, artificial intelligence. We have to see artificial intelligence as a general purpose technology. What is general purpose technology? General purpose technology are those technological innovations which have happened in the past where there was a tectonic shift in how things worked. Imagine those days when the roads were all filled with horse uh, cars, and suddenly when the motor cars came, how the change happened. That's the engine was a general purpose technology. The electricity was a general purpose technology which invaded multiple aspects, not just lighting but for various different usages. So similar to internet is a general purpose technology where we use it in various different dimensions. If we start listing out, so there is no end to where all we use internet, right? From Google Maps to navigation and to search anything and to even communicate like how we are doing. So that's general purpose technology. So what we have to come to terms with is like artificial intelligence is a general purpose technology which is going to change the way we live, change the way we interact. Basically, it's the computer capability to simulate human knowledge and cognitive processing. So see, to simulate human knowledge and cognitive processing, so which we assume is uniquely human trait. So there are three levels to it. The current state, which is the artificial narrow intelligence, and theoretical state of artificial general intelligence, and artificial super intelligence. So artificial narrow, whatever we hear, we see about artificial intelligence as of today comes into this narrow intelligence. As of today, what we have is this. And where we are heading to is artificial general intelligence. And if you see that green dot there, that's where we stand as of today. And that's an ideal state to be. And people wonder whether we really need to go to that level of artificial general intelligence or super intelligence. So why the experts are worried about reaching there? Artificial general intelligence is that level where AI builds on unrelated learnings to perform new tasks in different contexts and able to understand human emotion and relationships. It's like putting all the intelligence of every human being into one hard drive and making decisions based off that general intelligence. So that's can be perceived as a threat to mankind status quo. Beyond that is still the super intelligence where computer cognitive abilities exceed those of its human creators, and it will have its self-awareness of its own belief systems and desires. So that's it looks like science fiction, but theoretically the experts believe that it is possible to reach there. But as of now, we need to concentrate on narrow intelligence, which is the available thing at present. And these are some keywords, buzzwords, which we keep on hearing. As general practitioners of neurosurgery, who are 99% inside our operating rooms, operating on complex cases, we need to learn some of this terminology because we get bombarded with from various quarters about this. So I'm going to touch upon some of these terms and what they mean. Machine learning, natural language processing, large language models, generative AI, computer vision. Okay. So this is one example where multi-input mixed data hybrid model, where not just the clinical data is tabulated and used to predict outcome, but the laboratory data, histological data, and imaging data are also taken as native image output. It's not the report which is input, it's the native image, the histopathological section, as well as the MRI image, which is taken, and this can be transformed using deep learning to create output about predicting an outcome or to deciding a surgical strategy. Broadly, artificial intelligence can be considered of two parts. One is machine learning, which is statistical learning and optimization through algorithms. And second one is generative AI. In machine learning, so these are the categories: supervised learning, unsupervised learning, semi-supervised learning. So these are where how this differs is when we are training the machine in supervised learning, the output, the end result is already fed in supervised learning. We say like eventually the patient got relief of his radicular pain. So yes or no, that column will be there. It will be pre-labeled data in supervised learning. Whereas in unsupervised learning, there won't be that column of the outcome, and the machine is allowed with hundreds and thousands of data bits to learn in its own, seeing the eventual outcome, the overall survival or the relief from the radicular pain or a symptom, whether that particular intervention would have been appropriate, whether it is subtotal decompression or biopsy, for example, in gliomas, whether that eventually made a difference. So then over time, it would help to give us a decision about, based on that data and the eventual outcome, whether the intervention, which one is the most likely intervention which would give the best result. Semi-supervised learning and reinforced learning are based on reward and punishment. So we will nudge the machine when its training phase to say like, okay, this is a correct decision. No, this, if there's an artifact which it perceives as an aneurysm, we say no, this is not. That is reinforcing. So the biggest advantage with machines is rapid processing of large data sets, unbelievable and incomprehensible for our individual thinking. So that's the difference between our human intellect and the machine intelligence. The next one is generative AI, which will be useful in, for example, to create image which shows occipital glioma, for example, to create hundreds of such images for training purposes or for simulation purposes, for to check any other hypothesis on not the real patient data, but with generated images. So that's generative adversarial network. Here there will be two parts to this, where there will be one generator and then one adversary. Like this image where we give a prompt that create a picture of Mona Lisa in Van Gogh style. So this is what simple chat like ChatGPT or even our in our phones we can generate this kind of pictures. What happens is the generator will create every pixel and give a color to it and waits for the adversary to validate it. So adversary will do that millions of times for every pixel within a fraction of a second and say, yes, if it's a blue, it says yes eventually. If it's a red, no. If it's a yellow, it says yes at that certain point. And as it goes pixel to pixel over once it reaches the end of the screen within a fraction of a second, uh, which is very difficult to comprehend with our human mind, but that's what it has done, and it creates such a beautiful image. Either of the generator will not even know what Van Gogh means, what Mona Lisa means, but eventually, by the help of this adversary, which has its memory, which is pre-fed, will be able to generate this kind of beautiful images. Similarly, the MRI, if we say like grade 2 glioma, create 100 grade 2 gliomas in various regions, we'll be able to generate that and we can test it. It can be for training purposes or to use it for any other, even to create tractography data, you can use that. So, and what are the key machine learning algorithms? So these are some examples which we need to know, which are an extension of statistics which we are used to. So linear regression, logistic regression, decision trees, random forest, neural networks. So these are the different learning models. One curious thing which I noted was this neural network, convoluted neural networks particularly, are based on the data processing which happens in our primary visual cortex in layers. So the convoluted neural network is a simulation of biology in our occipital cortex. What I did was, in a quest to see what all aspects in neurosurgery has been touched with AI, there are some review articles which I went through, and in this one review, I could gather this simple summarization of where all we have in as of present day been able to touch upon. The AI to identify glioma tumors, diagnose intraoperative tumors, enhance postoperative care in spine, in epilepsy to identify epileptogenic zone, to identify suitability of patient for resections, and to predict outcomes. And in functional neurosurgery also to predict 1 year prediction of the outcome and the adverse effects of DBS in Parkinson's. So these are studies which are isolated studies to give examples. Okay. And machine learning to identify aneurysm rupture, AI to determine AVM risk factors, what the bleeding risk. So this is the convolutional neural network which I was talking about. So this there will be convolution, then pooling of data, and then there is an output. What happens in the middle is a black box, which I will come to later. AI in radiographic image analysis, lumbar disc classification, ML models classifying lumbar disc degeneration on MRI, which has reached expert radiologist levels, and CNS-based techniques for again this classification. That's the technique which is used in this. And in outcomes assessment, physician interpretation and patient-reported outcomes, where digital biomarkers, where mobile and wearable data are used, and even accelerometer data are used, where we can see the patient's recovery during rehabilitation period at their homes. Through internet, we can, in our devices, we can know the progress of the patient. Patient need not frequently visit our clinics. And AI enhanced patient selection, predictive analytics in decision making. So these are to be available in near future. As of now, to detect patients, particularly in complex area of CV junction, is can be aided based on imaging, but not available at present. Even in intraoperative tools, yes, in robotics, as I will show an example in our MaserX robot, navigation system, mixed reality tools, and it gives real-time guidance. If we have real-time ultrasound, intraoperative ultrasound with our navigation systems, that correction for the brain shift is possible using machine learning algorithms. So this is one curious example how we partner not just with our academicians and data scientists, but with also our patients, where this is one of my patient who came with a failed back after getting operated for lumbar fusion somewhere else in severe pain. What I had to do was a foraminotomy based on his imaging, and after that he got interested in how surgeons make decisions about fusing or not fusing. So he volunteered as an intern in our place and created a model where using random forest SVM, that is support vector machine model, and KN and K nearest neighbor model. So these are the three models in which the machine was trained, and the training data was based on MRI images of 10 separate patients, which was shown to the surgical residents, neurosurgical residents and consultants, and their decision about whether to operate, whether to conserve, whether to do discectomy only, decompression alone, or decompression plus fusion was fed to train the machine. And as the machine got trained, so it in the validation data, after the training session was done, the testing data showed an accuracy. Given a new data, how accurate its prediction would be about um, following the same principles of what a surgeon would have decided. Okay, that's a surgeon recommendation, and it was a kind of reinforcement where, as this app was created in a way, like for every new data which was tested, the surgeon would validate yes or no, so that the machine becomes more and more robust as it goes to say whether its interpretation gets more and more accurate over time. In our test data, after the training data was used, when we tested, so these two models, that is SVM and random forest models, provided an accuracy of 87%. Okay, so that was our small study. These are, remember, these are baby steps into artificial intelligence. So these are very, very initial. We are just scraping on the surface, whereas its potential is just, we will know that its potential only when we start exploring into what all little things we can do in our day-to-day practice. So this is in from a article by my friend who utilized AI heat maps to detect some of the things which routine radiologist would have missed in an emergency setting. So this particular subdural hematoma was missed in earlier CT scan. It was detected using a AI heat map. Whereas the other thing with the posterior, that little white dot was, which was a calcification, was detected as a hemorrhage, which was a false positive. So we should also note there can be some false positives. And this small aneurysmal bleb, 2 millimeter in size, was detected, which was missed out in the initial screening by the radiologist, was picked up as a heat map in using AI algorithm. Left MCA occlusion, another example. Again, the heat map from the algorithm correctly identified the occlusion. And the territory where the infarct is developing was also marked, the left MCA territory. So there can be false positive like this, where because there was a small venous loop around the vessel, it was detected as an aneurysm in this heat map. So it has its own positive. And what we have to remember is, as of today, the radiologist interpretation and validation is a must, and we can't just rely on AI heat maps. to diagnose or clear an image that it's fully normal. So data bias, because AI gets trained on limited data, it may fail in other groups. So these are the limitations. And that black box, which I mentioned earlier, that what happens inside AI is that AI's reasoning is something which we can't understand, we can't even see. And that lack of transparency is the biggest roadblock for surgeons as well as our patients, as well as the medical legal system to take it directly without any thought. And liability. Who is responsible if an AI guided decision harms the patient? And equity. High cost of AI tools may widen the healthcare disparities. So these are the limitations which we need to keep in mind. I spoke to you about the technology life cycle, and as surgeons, as medical professionals, particularly surgeons, particularly neurosurgeons, we are ready to embrace any new technology. We are the last. Unless the whole world proves that it is infallible, only then we are going to take. So we need to know what is happening now is like that time gap between something coming into existence, the innovation trigger, and which comes to us. For example, if you take CT or MRI, it took few years for us to get amalgamated into our practice, whereas with the new advent of AI, the new technology, that time gap has shortened and we are reaching that peak very soon in a matter of few years. Just to remember, ChatGPT started only in 2023 November or so, and now it's almost like not a day passes uh, without utilizing it for even routine details. Without rather than going to any other internet search engine, people have started using that kind of uh, chatbots to know more about the particular question, which is a personalized answer. Okay, so now this is in 2021. You can see how it was spread across this hype curve. Whereas the new in that, as we come to 2024, we see already the generative AI, which was such hyped up very recently, is already in its trough of disillusionment. We are coming down there. And what is coming up now is the digital twin, where in how it affects medicine is like to have a digital twin where we can do virtual surgeries, for example, clipping of an aneurysm on a digital twin before it's actually performed on the patient. Okay, so that's in an upward curve. The innovation trigger has happened, and there's a peak of inflated expectations. So this is a kind of as a technological observer to see outside, coming out of our theaters, coming out of our practice to see where we are heading with respect to technology, and to see AI in particular as of this year. So where we are, generative AI has further gone down, and we are soon to reach the trough of disillusionment, and then slowly we'll get into the slope of enlightenment. And what is new is that quantum AI, okay, and AI simulation, artificial general intelligence, which will take significantly longer time, not very soon. AI agentic AI. So these are the new things which are coming up in the field of AI, which we need to know as content words, because invariably, even though as of today we don't know much detail about it, invariably we will be bombarded with that use cases where even our patients will be making compelling reasons for us to explore and understand what that means. A short video about usage of Maser-X robot for a use case here is of a CV junction anomaly. It's a short video, just bear with me to see. We're using OARM navigation, then marking our area of interest. This was a case where an occipital screw was possible to be placed just because the robot gave us that confidence that we can actually do in this case, where the occipital condyles were hypoplastic. This was a pro-atlas segmentation anomaly with severe compression at the craniovertebral junction. And with this small hypoplastic occipital condyles, I would have otherwise used the occipital plate, but because of its guidance, which gave a sense of security and confidence, so we were able to place screws on the occipital condyles. Let's see the end result. Those are the condylar screws. So just to see and to bring us some solace, we stand in this upper right corner where AI is going to affect our practice. Whereas those specialties which are repetitive as well as data-based, like radiology, dermatology, ophthalmology, are the ones which are easily it's possible for AI to replicate and do most of the jobs where the work, clinical work, is repetitive as well as data based. Whereas it is creative, every interaction carries some extra information about how we treat, even though it's repetitive, like geriatrics. So it is the new technologies like AI will play a limited role in these professions. Whereas in neurology, we can see it will impact our neurology and neurosurgery, but it won't change the interaction based nature. So this is just to get an overview of how AI would impact our practice, day-to-day practice. So this is the now often quoted word, like these physicians who use AI will replace those who don't, and AI will not be able to replace the physicians. So these are again, FDA has approved a new way to approve, because these are systems which learn over time, and when they are first FDA approved, they are not yet in their final stage. That's the difficulty to validate or approve, license any AI device. But now it has found a way to give a skeleton about how we are going to incorporate the newly available data in a timeline. With that, there are a lot of new FDA approvals for AI-based devices, AI-based softwares. The challenge is the black box of AI, which is in the center, which we don't know how. And the second question is about who is responsible when a mishap happens. The solution for that is to have a collaborative approach, not just following AI, but to use AI as an associate, fully knowing the limitations. So we are not competing with AI, but we are competing with AI with our side against the diseases which we need to take care of our patients. The other aspect of it is with all this commotion happening about AI and with the lack of clarity about how it's going to affect our day-to-day practice. Being neurosurgeons, we are endowed and we are having that additional responsibility to guide people who are into this AI research about what makes us human, because we have seen the brain and we see it every day, and then we see how it behaves. You imagine that awake craniotomy. Even today morning, I operated on a temporal glioma when the patient was awake and he was able to explain everything I'm operating on. Just step aside and see what is it we are operating upon, and who is he who is actually being able to respond to my questions when I am operating my brain. So it's very easy and very intuitive to think that what we believe as us is our body. But is there a hidden driver within our brain? Is there somebody who triggers the action utilizing the hardware, like a driver utilizing a car? Like, it's not our body, we know, because we cut it, we sew it. It's not just the body which defines what is us. It's in this kind of extreme cases where we see with awake craniotomies, we are very sure like it's not just the sense of eye is not just lying within that tissue of brain. And when, as with examples with hemispherotomy, we see that it's not essential for the entire brain architecture to be intact for a human being to behave as such. So where does human intelligence remain? What defines us as human? Is it that we think? Is it that we can memorize? Machines have clearly shown us. So this is an aside note, aside from what we just discussed about its implication in neurosurgery. So we are coming to that crucial philosophical question of what defines us as human. This is example of free will. If we imagine we have a free will whereas AI does not, think about this example of toxoplasma, which can get into the brain of the mice and make its behavior change, alter to get it attracted towards a cat. This is what the toxoplasma parasite does. It changes, alters the behavior of mice and makes it it feels the cat as amusing and just gets into its trap and gets killed. The underlying thing is like the toxoplasma wants its life cycle to continue, and that's why it just has its curious natural way to get into that area of hippocampus and make the mice get attracted to the cat. And the mice will think it is its free will that why it is behaving that way, but actually it is the toxoplasma which is making the thing. So with this, to give an example, like whether we consider it as empathy, our thinking capacity, our memory, or our free will, everything can be replicated by the machines. So then we come to that philosophical question about what it means to remain human when everything is possible utilizing machines, artificial intelligence. So there's time to think of new terminology for that augmented intelligence, which is against just AI, which is mimicry of human cognition through algorithms and data. Augmented intelligence is a collaboration between humans and machines to enhance decision making and insight. And the absolute intelligence would be that intelligence which is not about anything, but which is that awareness, which is a witness to everything happening around us. So we will be grappling such philosophical deep questions as we venture into this very nascent field, which we have very little time to know it fully before it hits us on a day-to-day basis. To conclude, again, like with this kind of different dimensions to this, when I fed this material to AI, this is how it concluded. So what does it mean for AI in neurosurgery? AI augments neurosurgeons across all the care continuum. The key benefits are precision, personalization, training, and knowing survival data. But we have to be cautious about ethics, transparency, and human oversight is paramount. AI empowers but not replaces the neurosurgeon. So with this, we'll come back to our practice of medicine and that wise words of Sir William Osler that even though we can delegate much more to know about the disease to machines, we have to keep in mind that it's much more important to know what sort of a patient has a disease than what sort of a disease a patient has. Thank you very much.
Okay, well, thank you very much, Prof. Komal Prasad. I just admire your presentations every time I see it. I feel like
Thank you.
having a look at it more and more. So, as you really said that neurosurgeons are the last people to adapt to a new field. I think
Yes.
because the consequences of even a minor mishap is like overwhelming. That is why we have to be absolutely sure. Well, nevertheless, it was very interesting. Thank you very much for these very wonderful presentations.
Thank you very much, Raja.
Fine. So I'll close this webinar now officially on behalf of the Education Committee of the ACNS and the President Prof. Yoko Kato. I would like to thank both speakers of today, Dr. Silvio Sarbo and Dr. Komal Prasad, as well as the Chair, Prof. Ken Matsushima, for the time and support for the ACNS webinars. A special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. As I mentioned earlier, we have around 575 people who have logged in through all the different channels, and also special thanks to my co-host Lyubun Singh for joining me today. So that's all for now. Until we all meet online tomorrow, it is bye bye from all of us. Thank you very much for joining.